Good afternoon, everyone. Thank you for joining us today. This webinar is sponsored in part by an educational grant from Novartis, and we thank them for their support. My name is Ashley Ring, and I'm the Associate Director of Public Education here at the American Kidney Fund. I'd like to introduce today's speaker, Dr. Rupi Sodhi. Originally from Danville, Illinois, Dr. Rupi Sodhi came to St. Louis to start her undergraduate education at St. Louis University. After completing a bachelor's degree with a major in finance and minor in biology, she started her medical education at St. Louis University School of Medicine. Dr. Sodhi earned a dual degree, MD, MBA, and went on to complete an internal medicine residency and nephrology fellowship at SLU. During her nephrology training, she became particularly interested in the care of transplant patients and went to Washington University School of Medicine in St. Louis to complete a transplant nephrology fellowship. She returned to SLU to join the faculty as an assistant professor of internal medicine in the Division of Nephrology. Dr. Sodhi currently works as a transplant nephrologist with a concentration in the care of transplant and immunosuppressant management. Thank you for joining us, Dr. Sodhi.
Oh, thank you for having me. So hello, everyone listening, and thank you all for joining this webinar today on a topic that I'm particularly excited to talk to people about. The goal of the talk today is to discuss what life is like after kidney transplantation. A lot of patients who are on dialysis get a lot of education about what it takes to be eligible for kidney transplantation, and you learn all about the criteria not only for surgery but for emotional setup and support, and what your house and living situation and finances need to look like before kidney transplantation, but there's very little education for what happens after transplant. And a lot of times our patients go through the surgery and their expectations or their ideas in their head about what was going to happen are very different from the reality of caring for a renal transplant. So the goal of the talk today is just to go over some of the things that patients and their families can expect after a successful kidney transplant. Some of the topics that we're going to cover today include the physical challenges that patients face after transplantation, the role of immunosuppression and the medications associated with that, the emotional and psychological aspects of kidney transplantation. A lot of patients don't realize that this is a large part of caring for a kidney transplant. We also will touch on the financial responsibilities that patients and their families will face after the transplant, and really at the end of the talk try to touch on what your new normal will look like when you are no longer a dialysis patient. So we're going to start the talk today by just discussing the physical challenges. And this is really the most common thing that patients and their families ask about, because in their head, this makes the most sense. We're going through a surgery, so we kind of need to know what our bodies are going to be like after we come out of surgery. So, you know, your physical health and function before transplant is a very strong predictor of your physical well-being after transplant. And I tell patients this because I think it's hard for people to wrap their heads around this. You know, dialysis is really a full-time job for patients, and it is exhausting. You know, I have patients come in when they're getting their pre-evaluation done, and they say, you know, I go to dialysis, I have to get up at sometimes 4 o'clock in the morning, sometimes 5 o'clock in the morning, or whatever time they have to get up. They go to dialysis. It's a 4-hour ordeal. They're transported back home either by their family members, or they transport themselves, or they rely on public transportation. And by the time they get home, they're completely wiped out, and they sleep for several hours. And really, it takes them almost a full day to regain their strength back. And when they finally start to feel better, it's time to go back to dialysis. So at the time of transplantation, when we're evaluating patients for transplant, we sort of ask them questions about what they're able to do at home, how much assistance they need, how much they can take care of themselves and do their activities of daily living. And there is a scale that we use to sort of give patients a score on how independent they are. And that scale is called the Karnofsky score. And the Karnofsky score was initially developed by oncologists when they were trying to determine which patients should receive chemotherapy. And a lot of that was based on how functional the patients were before they ever started the medication. Well, it's been adopted by solid organ transplantation to determine which patients will do better after transplant. And now the United Network of Organ Sharing has deemed that every patient who undergoes an evaluation for kidney transplantation get a Karnofsky performance score. And the score goes from 0 to 100%, and you can see on the screen sort of how we categorize where a patient falls and what score they get. And what they found is when they looked at all the patients who got kidney transplantations, and even this held up for liver, heart, and lung as well, the higher the patient's score was going into transplantation, the longer the transplanted organ lasted, and the better the patients did as far as quality of life and how long their lives lasted after transplantation. So we always tell our patients that the more independent you can be, the more you can give yourself self-care, the better off you'll be after transplant. A lot of patients ask about pain after surgery. The surgery is, most patients don't realize, but the kidneys are transplanted and implanted up in the pelvis. So your native kidneys are actually in your back, but we leave those kidneys there and we implant the new kidney in the pelvis. And so because of that, it's much easier for the patients to recover from surgery because it's a much less invasive surgery than going in through the back, removing the old kidneys and then putting a new one in. Most patients are tapered to oral medications within 24 to 48 hours, and they're sipping on water and eating ice chips even right after they come out of the operating room. Early mobility is definitely the key to pain control, and this is why it's so important that patients are mobile and active going into surgery, because those are the patients that are much more willing to get up and move after surgery. In fact, most patients wake up from kidney transplantation feeling great, especially if the kidney has kicked on and worked right away in the operating table, and we almost have to hold the patients down in bed the first day to make sure that the wound heals okay before they try to jump up and start walking. But we don't actually go in deep into the abdomen, so there's not much in the way of healing that needs to happen. But definitely the patients that are able to sit up and move around do much better after surgery, and most patients have very, very well-controlled pain by post-op day 1. The next challenge that patients face are the changes in weight. So most patients who are on hemodialysis know exactly what their dry weight is, and that's the weight that we try to get the patients down to at the end of each dialysis treatment. Immediately after surgery, patients notice that they're much heavier than their listed dry weight, and that's because during the time of surgery and even after surgery, we give our patients a lot of IV fluids, and there's a few reasons for this, but mainly it's so that we want the patients to sort of have a little more body water on board going into the surgery so that their kidneys will be nice and well perfused, or the new kidney will be nice and well perfused when we're implanting it. Additionally, if the kidney kicks on right away and starts dumping out urine, patients can I've seen patients make 5 liters, 7 liters, 10 liters. I even had a patient one day make 17 liters of urine in the first day. So you can imagine we need to give that much fluid back to make sure that our patients don't get dehydrated. So that being said, you are getting a lot in the way of IV fluids in the first 24 to 48 hours of surgery, and your dry weight will be affected by that, and the patients will often be 5 kilos and even almost up to 10 kilos positive by the time they leave the hospital. That weight will come off over the next several days, because if the kidney is working, the patients will eventually just pee all that fluid off. After that, though, the patients do notice that they start to put on weight, and there's a few reasons for this. One is that a few of the medicines that we give you for immunosuppression, particularly tacrolimus and the IV steroids that we give you at the time of surgery, do stimulate your appetite. The maintenance immunosuppression steroid dose is very small, so it's not doing much to stimulate your appetite. But at the time of surgery, you get a whopping dose of steroids that will stimulate your appetite. And that will cause the patients to gain a little bit of weight just because they're eating a little more. Tacrolimus in and of itself causes a little bit of weight gain. The second reason is that now that you don't have a failing organ, you are filtering out a lot of toxins that suppress your appetite. So dialysis patients feel like they're eating enough, but in actuality, they're probably not eating what they would eat had their kidneys been working. So they just tend to eat more. And additionally, all the restrictions that you had with your diet go away. So patients can start eating foods rich in phosphorus, rich in potassium, and all the things that they had to stay away from in order to not get into trouble on labs now disappear, and they can eat all of those things. So patients tend to gain weight after transplant. Additionally, if you were not in the habit of exercising going into transplant, it's very difficult to learn to that habit after transplant. And so what we do see is that the average weight gain post-transplant is around 30 pounds. About 10 to 15 we sort of expect because, like I said, patients with kidney failure are mildly malnourished. And so we do see a little bit of weight come back with a working kidney. But once you pass that 15 or 20 pound mark, most of it is due to increased food intake and lack of exercise. So we always tell our patients that exercise is very essential to managing weight gain and associated complications after transplant. And if you're not in the habit of exercising before transplant, you should get into that habit because it's very hard to start a new exercise regimen after surgery. I tell my patients, even if you just do 15 minutes 3 times a week where your heart rate is up, that is good enough. That's enough to make it a habit, and it's enough to carry on after transplantation. The next thing we're going to talk about are the role of immunosuppressive agents. So these agents are designed to keep your kidney from stimulating your immune system and causing a rejection. So we're going to talk about what an immunosuppressive drug is and how it works and why it's important to adhere to these treatments as prescribed. Our bodies are very, very smart. Our bodies are designed to recognize what belongs to us and what doesn't. And that is why we are able to fight off diseases from bacteria and viruses, because our bodies are very smart at figuring out what belongs to us and what is a non-self entity. And when it recognizes something that's not yourself, it learns to attack that. And again, that's how we are able to fight off any kind of invader into the system. And on the next slide, I think we're going to discuss, so when you get a kidney, it clearly does not come from you. It's either from a cadaver of somebody who's passed away, or it comes from a living, either related or unrelated person who has donated their kidney to the patient. And the job of the transplant surgeons and the transplant nephrologists at that time is to stop the host body from attacking the new kidney, because your body will, again, be designed to recognize that that kidney does not belong to you, and we're going to have to reroute what is hardwired into ourselves so that you don't attack that kidney. And how we do that is at the time of surgery, we usually give you some IV medications, and which we call induction agents. There's a handful of them out there, as well as some IV steroids to start suppressing your immune system and wiping out some of your immune fighting cells right away. And after that initial post-transplant period, we put you on 2 to 3 oral medications for the life of the kidney. And again, the point of all these medications is to stop the immune system from attacking the new kidney. And because of that, it's very, very important that patients strictly adhere to the medication schedule. Some of these medications need to be dosed exactly 12 hours apart. Some of them are once a day, some of them are twice a day, but the timing isn't as important. But it's very important that you stick to the schedule that your transplant center gives you and you don't miss any medications, because even missing 1 dose of one medication could be enough to set off a rejection. And the problem with kidney rejections is that they are most often silent. And what I mean by that is that patients do not get symptoms when they have kidney rejections. Usually rejections are picked up on routine lab work that you're getting after the transplant period, and your creatinine starts to go up. Now we'll call the patient, we'll say, "Are you feeling okay?" And they'll all say, "Yeah, I'm doing fine. I don't feel anything. I feel great. I'm still making a ton of urine. What's the problem?" And so we'll have to bring them in to see if we can figure out why their creatinine is going up. And every once in a while, we will get to the point we've ruled out a lot of things like dehydration or some sort of a stricture or something like that, and we'll have to do a biopsy, and sure enough, we'll find a rejection going on. And usually that's when it comes out that from the patients that, oh, there was one night where I fell asleep and I forgot to take my evening dose of tacrolimus. And sure enough, that was enough to kick off a rejection. So strict adherence to your medication schedule and timing is very, very crucial for maintaining your kidney health. Again, like I said, this is very challenging for patients initially because the dosing of the medications in some instances needs to be timed. Some medications need to be taken with food. Some need to be taken without food. And on top of that, some of the medications we dose based on your blood levels, and so we're constantly adjusting that dose. Go up by 1 milligram, go down by 1 milligram. The labs came back and showed it's this. So there's a lot of frequent adjusting of the dosage, and there's a need for lab draws after the medications are adjusted to make sure that we're hitting our targets appropriately, that we're not overdosing or underdosing you. So it is a lot of work for the patients. These medications are also not without side effects, so they work beautifully to help keep the kidney going and keep your body from rejecting, but they do cause side effects. Some of the immunosuppression medications can give you fine tremors in your hands. It can cause hair loss. A different medication called cyclosporin is known to cause hair growth in places where you don't want hair growing. Certain medications are more likely to suppress the cells that help you fight off infections. So while you are on these medications, you may be prone to developing problems with different viruses. You can see metabolic abnormalities. They contribute to high cholesterol, high triglycerides. It can cause worsening of your blood sugars, particularly tacrolimus has been found to do that, and also can cause more elevations in blood pressure than normal. This is not common. Most of the time people come off of many of their blood pressure medications after transplant, but some patients who didn't have problems with blood pressure before transplant can develop the need to take some blood pressure pills after transplant. So it's very hard to determine who's going to get what side effects, but any or all of these can happen to people, and we just tell the patients that they have to be prepared to deal with these side effects. A lot of these side effects we can deal with just by switching out medications for different either name brand or generic or different formulations of the same drug. So it's usually very fixable, but it's very important that you know that these things can happen. And we always encourage the patients that should you experience any side effects whatsoever, that you need to tell your doctor right away so that they can make adjustments to your treatment early on. Next, we're going to talk about the emotional aspects of kidney transplantation. And this is a little harder for patients and their families to wrap their brains around, because I think everybody is just so excited to come off of dialysis that it doesn't occur to them that there could be some emotional issues that can come up after transplantation. So the first thing I always tell patients is that if you have an underlying mental health disorder before transplant, and that can be mild anxiety, depression, bipolar disorder, these things can worsen immediately after transplant. And it's through no fault of your own, but it's just because the way the medications can affect your mood. These underlying diseases or disorders that can affect your mood, even if they're very well controlled going into transplant, you can see exacerbations of these after transplant. So we tell our patients that if you have a diagnosis of depression at any point in your life, or anxiety, or bipolar, or schizophrenia, that it's very important that you have established care with a psychiatrist or a psychologist. And it's important to know going in that these things can temporarily worsen because of the medications that you'll be on. So we encourage patients that if they're very stable on their medication regimens, that they notify their mental health care providers if they are called in for transplantation, because they will need close and more frequent follow-up in the early transplant period. And even if you do feel well and no medications are being adjusted, it is just very important to continue to follow up with your mental health care providers. The next thing that we're going to talk about is guilt. So this is something I don't think people realize they're going to feel until you get your transplant and it happens. But patients at times can feel an overwhelming sense of guilt, whether or not they receive the kidney from either a living or a deceased donor. With living donors, there is some guilt associated with accepting an organ from a family member or a friend. And even in the pre-transplant period, patients feel very guilty even asking people to donate kidneys. And we have, developed techniques nationally to sort of help patients out with that. There's a program called the Living Donor Champion Program that's even offered at transplant centers now that teaches patients how to talk about their disease without feeling like they're soliciting for organ donors, but just to raise awareness and sort of bring to light the importance of living donation in the country. But even when patients do that and they get kidneys from family or friends, they do sometimes feel guilty afterwards for having accepted an organ. For cadaveric donors, a lot of people have a hard time dealing with the emotional burden of receiving an organ from a deceased person. The United Network of Organ Sharing and the different organ procurement organizations around the country do a very good job of trying to keep the information about the donor hidden from the patients early on, because they want the families of the deceased to be able to mourn the loss of their loved one and have that time. And they also want to minimize the amount of contact that the recipient's family and the donor's family have with each other up front. There are specified periods of time, and that's specific to the different organ procurement centers in the country. Some say 6 months, some say a year, before they let the donor or the recipient family contact the donor family to write letters of thanks, et cetera, et cetera. But there are people that feel very guilty, and that guilt can make them want to reach out to the family of the deceased person, and it sometimes makes them not want to reach out. And there's no right answer to this. There's nothing that says it's right to contact the donor family or wrong to contact the donor family, and this is something that patients and their families struggle with. I've even seen within families where the recipient does not want to know anything about the donor, but the wife or the husband of the person who got the kidney wants to know everything. So it does change your family dynamic a little bit, and it's important to know that this will come up, and it's important to talk about these things before you go through transplantation. Again, patients feel a great burden of responsibility. Caring for a transplant organ requires a lot of effort. There's complicated medical regimens, and there's frequent office visits, blood draws, even hospitalizations after transplant. There is a great deal of responsibility, and it can be overwhelming. I do tell my patients it takes a village to get one patient, one kidney, and keep it going for several years. So patients who are not used to asking for help and like to do everything by themselves, I tell them during their pre-transplant evaluation that they're going to have to let go of that, because they will need help. They cannot do everything by themselves. And the more you try to take on that burden by yourself, the more overwhelmed you can get. And it's important for patients to know that complications often happen, even when you do everything perfectly. You take your meds on time, you take them exactly when you're supposed to, you do your labs exactly how you're supposed to do them, you come to all your clinic appointments. There will always be complications. Some kidneys are very slow to wake up in the post-transplant period, and some patients may require a short continuation of dialysis after transplant. And this just mainly is a result of how long number one, the manner in which the donor died, and also how long the kidney was in transit between the donor and implantation into the recipient. Most of the time, those kidneys work just fine, but they do take several weeks to wake up, and somebody can be on dialysis for a day or two, somebody can be on dialysis for a week. Some people I've seen on dialysis for 3 to 4 weeks before the kidney wakes up. They do wake up, and they do work great. But this can often be very taxing emotionally on a patient who thinks they're going to wake up from surgery making tons and tons of urine, and they're told, well, we're going to have to take you to dialysis tomorrow. There are multiple office visits and hospitalizations that can occur through no fault of the patient. Like I said, you're getting lab draws about twice a week after the after surgery and after you're let home for several weeks. And we do that because, again, a lot of the problems that can happen with a kidney transplant are silent problems, meaning that clinically you will not feel any different. You'll actually feel fine. But we monitor the labs because we can sense when things are going wrong, and we can get you into the hospital and fix them before the kidney is damaged. You can have some worsening of associated medical conditions, meaning that, like, if we talked about this earlier with some of the side effects of medication. So some patients have worsening blood pressure, some patients have worsening blood sugars, they can get elevated lipids, et cetera, et cetera. So it's important to follow up with your doctors. And this can often lead to frustration, new onset depression, new anxiety if you've never had that before, or exacerbation of underlying depression and anxiety that's been there. So it's very, very important that our patients know that we expect complications to happen. We don't ever blame our patients when they come in with an infection. Urinary tract infections can be quite common after transplant, and because you don't have an immune system, a simple UTI can land you in the hospital with a fever. And you'll need IV antibiotics for several days. Again, it's not through any fault of the patient, but we just want them to know that we expect these things to happen and we don't want them to feel frustrated. Keys to improving your emotional health. I think what I tell my patients is involve your family and friends early in the process. You know, when you're going for transplant education, when you're still on dialysis and you're learning all about transplantation, most often patients just bring whoever is living with them. But if you have a large family or friend network that, you know, is going to ever be involved in your life as far as helping you get to doctor's appointments or, you know, being there for you emotionally, bring them to education. I tell my patients, if you have an entourage, bring your entourage. The more people we can educate, the better. I think it's important for patients to manage their expectations. So, you know, all the things that we just talked about, know what you're getting into, because if you are somebody who's had very controlled depression for years and years and years, and all of a sudden you get a transplant and you're crying all the time and you have no idea why, you can really start to get down on yourself. And patients who don't have good emotional health, their kidneys don't do well. So always manage your expectations and know that complications will happen. We expect them to happen, and we will work with you to try to get you through those things. And most importantly, always stay in contact with your transplant team, your coordinators, the nurses, the physicians. Everybody's there to help you. We always tell our patients there's no bit of information you can give us that's too small. I tell my patients, I joke with them, if you get a hangnail, I need to know about it, because what you all think is seemingly small and minute and you don't want to bother us with little things can sometimes escalate into something really big. And by the time we find out about it, it's out of control. So it's always better to tell us too much rather than not enough. Next, we're going to touch on the financial responsibilities that patients and their families face after transplantation. I always ask my patients when I evaluate them for transplant, why do you want a kidney transplant? And the number one answer everybody gives me is, I want to get off dialysis. That's pretty standard. And the follow-up question that I have to patients is, well, why do you want to get off dialysis? And that answer is never the same between two people. And a lot of that ties in with the financial responsibilities that patients and their families face. So the most important thing I think people need to realize is that when you are on dialysis, regardless of your age, you qualify for Medicare. And so if you are a 39-year-old person with end-stage renal disease because you've had bad high blood pressure and it killed your kidneys, you qualify for Medicare. However, if you get a transplant, Medicare gives you a 36-month limit to continue after transplant, and then it will end if you are under the age of 65, 3 years after your transplant. And this is important because most patients, this is their only form of insurance. And this is why many transplant centers, probably most transplant centers in the country, I know ours does, requires patients to have a secondary insurance. Because if Medicare runs out and all of a sudden you have no money to pay for your medications, you will not be able to afford them. If you had to pay for just your 3 immunosuppression medications out of pocket, it would cost about $20,000 a year. So it's very important to have careful planning prior to transplant, to think about, do you want to return to work? If you don't want to return to work, do you have another condition that will qualify you for disability? If not, do you have somebody living in the house or can provide you with sufficient funds to maintain your lifestyle and your home if you are unable or unwilling to return to work? The next thing I want to touch on is that Social Security disability that's linked to end-stage renal disease gets reviewed within a year after transplant. And your disability status, if your transplant is successful, may disappear as soon as a year. So if you are on a disability-based insurance like Medicaid, that may disappear after a successful transplant. Again, it's important to discuss with your family and your support system what your financial picture is going to look like should all these things disappear. Lack of transportation. So this is a big problem for a lot of patients. A lot of times patients lose transportation because of lack of insurance, and it seems a little counterintuitive, but let me explain. So in Missouri, for patients who are on disability like Medicaid or even Medicare patients, they arrange rides through their insurance to and from dialysis because they don't have anybody to take them 3 times a week. A lot of these patients are not allowed to drive, can't afford a car, or aren't safe to drive. In Missouri, we have something called Call a Ride. I don't know what it's called on the East Coast, but I'm sure they have something similar. Once you lose your insurance, that covered ride pickup disappears. And so you lose coverage for transportation to and from your appointments after your disability ends. A lot of transplant centers are located at significant distance away from patients' home. Here at St. Louis University, we have patients that come from Indiana, we have patients that come from Kentucky, Illinois, Arkansas, even Oklahoma, to get evaluated for transplantation. Some of them live, anywhere between 2 and 8 hours away. And if you're relying on insurance-covered transportation to get you back and forth, these are things that become a problem after transplantation. And again, if you get lost to follow-up or you miss blood work or you miss clinic appointments, it can compromise the health of the kidney itself and also the health of the patient. So knowing all this information, then we often get asked the question, well, why would I do this to myself in the first place? Why should I get a kidney transplant? Because right now I have the hang of dialysis. I know exactly what time I need to get up. I know exactly how to structure my day. I'm really, really good at being a dialysis patient. So why would I go through all this? Well, the benefits of kidney transplantation are far outweigh the risks, in my opinion. The kidney transplant is the best treatment for end-stage kidney disease. Dialysis is not a treatment for end-stage kidney disease. Dialysis is a way to keep you alive despite having kidneys that don't work, but it is not treating anything. The 5-year mortality rates for patient on dialysis is anywhere between 40 to 60%. And that, what I mean by that is, if you look at all the patients who are on dialysis and you pick any point in time, if you go out 5 years from the time they started dialysis, only 40 to 60% of those patients will be alive at that time because 40 to 60% will be dead. Coming off dialysis improves your quality of life for reasons we discussed earlier. And not only that, but it also improves your survival. Your families benefit from you having a kidney transplant. You benefit from having a kidney transplant. If you look at the graph on the next slide, it shows the survival percentage of, I believe this is 5-year data, for patients on dialysis versus patients that received a cadaveric kidney transplant versus patients that received a living donor kidney transplant. And as you can see, who is left standing are the patients that received kidney transplants. There's a significant survival benefit to getting a kidney transplant. Of course, living donor kidney transplants last longer and the patients do better than the deceased donor, but both of them are significantly higher than just maintaining on dialysis, which is why we encourage all patients who are on dialysis to at least come forward for evaluation. It doesn't mean everybody's healthy enough to undergo a kidney transplant, and sometimes going through surgery is worse than not, but we always encourage people to at least consider this option. The other nice thing about having a kidney transplant is that in many instances, there is improvement in related illnesses and complications that result from end-stage kidney disease. So I did tell you some patients have worsening high blood pressure, but the overwhelming amount of patients that get kidney transplant actually have improved blood pressures, and they're able to come off of several of their antihypertensive medications. The anemia associated with chronic kidney disease and end-stage kidney disease improves, and your bone health improves, so you won't have to be on phosphorus binders anymore. And in fact, the most dialysis patients know about this, but the parathyroid hormone level that we monitor, it actually improves after kidney transplantation, and you don't have to worry about possibly needing a parathyroidectomy. And again, we discussed this earlier, but all those dietary restrictions that you're on when your kidneys have failed tend to disappear. So patients are able to eat what they want and enjoy meals with their family, and not have to worry about people making exceptions for them and preparing other food. So what does life actually look like after transplantation? So the next few slides are going to cover what the new normal looks like. Well, what patients can expect are increased energy levels. No more of this coming home from dialysis and being wiped out. Our patients do really, really well after transplant and feel like new people. Again, because especially in the first 3 to 6 months, because all those toxins that have been swimming around in their body that weren't getting cleared out, all of a sudden just start to drain out of their system, and they feel great. Patients tend to have more time with their family and friends, and also travel becomes easier and more feasible. So we have a lot of patients come in and say, well, I want a kidney transplant because I have family, sitting in California that I never get to see because it's a pain to set up dialysis in another, state, or travel with my peritoneal machine, et cetera, et cetera. So these people all of a sudden have a lot of liberalization to travel when they want. They don't have to make any plans. They can take spontaneous trips, and they love it. A lot of patients come in and say, well, I want to go back to work. I used to work until my kidneys failed, and I loved working, and now I'm on dialysis, so I can't work, and I really want to go back to work. And when patients return to work, we find that a lot of them have improved feelings and attitudes, and they don't feel that despair and depression that can be associated with chronic dialysis. They're out in the workforce, contributing to their family's income, contributing to society, and doing meaningful things. And even patients that don't go back and work, patients that get kidney transplants after they retire, a lot of them go out and do volunteer work, and it really gives these people a renewed sense of purpose. Patients just feel better overall, and they just have a renewed sense of faith and love and joy that gets infused into their lives, and it's very rewarding to see. So instead of focusing on getting yourself to and from dialysis or performing peritoneal or home hemo treatments, the focus will be on keeping your new kidney healthy. And a lot of this involves just following medication regimens and instructions and attending follow-up visits, which sound like it wouldn't be that hard, but it's very burdensome up front. Patients are usually seen once a week in clinic for the first several weeks. They're getting labs twice a week. Their medications are being frequently adjusted, all the things that we talked about earlier. We do tell patients that most complications happen soon after transplant, so the most vulnerable time for complications tend to happen in the first 6 months. And then definitely in the first year, a little less in the second year, and then even less from year after year 2 through the life of the kidney. But the complications early on tend to either be infection or rejection. Many of these complications are reversible as long as we catch them early, and compliance plays a key role in the frequency of the complications that patients experience. However, remember that I said, even if you're perfect and you follow all the instructions perfectly, you still could get a complication. So it's important to know that sometimes these things just aren't your fault. So what are tips that we can give our patients to have the best post-transplant outcomes? Well, again, using your resources is the most important thing. Your coordinators, your social workers, your physicians, we're all here to help you, and we want to help you. Everybody wants to see the patients do well and to have kidneys that work, and they work for several years. We encourage our patients to involve their family and friends early in the transplant process, so the more involved they get on the pre-side leading up to transplant, the more involved they'll be after. It is sometimes harder for people who haven't been involved in any of the planning for transplantation or even the surgical part of it to start getting involved, 3 to 6 months after the surgeries happen, when all these complications that could arise do arise. It is sometimes hard for people because they don't really understand what you've gone through. Again, managing expectations is extremely important. Knowing what is realistic, what is not realistic will help maintain your overall mental and emotional health and even your physical health. Understanding that complications can happen, understanding that your emotions and your mood could be out of sorts for several weeks. Knowing that you're going to need to rely on your family and friends a lot up front for rides and assistance at home. All of these things go better when you know these things going into the surgery. And planning ahead always helps. So deciding before surgery who will help organize your medications, setting alarms to remember to take your medications, using pill boxes. Most transplant centers have a transplant pharmacist that goes over and helps set up the pill boxes at the time of discharge. And the coordinators are very good about walking you through anytime there's a medication change. They'll help you go through your pill box over the phone. Sometimes they tell you to bring your pill boxes into clinic, and we just empty the pills out right there and show you what you should take, how much of one or the other, what we've adjusted. They go over all these things. Again, everybody wants to see our patients succeed, and we all want to do what we can to help in that process. So to summarize what we've talked about, again, kidney transplantation is the best treatment for end-stage renal disease. The more educated our patients and their families are before transplant, the better survival that the patients and their kidneys have. Again, incorporating healthy diet and exercise into your life prior to transplant will help both with your surgical recovery and with the weight gain after transplant, and also just with your overall emotional health. Exercise always releases endorphins and adrenalines, all of which can help sort of mitigate some of the overwhelming anxiety that can be associated with transplantation. The emotional burden of receiving a kidney transplant can be overwhelming, but it's still a life-saving endeavor. I always tell my patients, remember, when you get a kidney, that is you standing up and fighting for your life. Kidney patients don't look sick. They don't look like other patients who have organ failure because of dialysis. They can get their toxins cleared out and look normal. So people tend to not know what end-stage renal disease patients are going through. And you getting a kidney transplant, you coming forward, is you fighting for your life, and it's an admirable effort. It's important for patients and their families to identify who will help with the emotional support after surgery. And again, if any of this can be planned out before the transplant, the better off the patients will be. And remember that complications will happen. I can't stress it enough. I know it sounds like I'm beating a dead horse here, but it's really important to remember this. Don't ever take these complications personally or feel that you have done something wrong. We expect it to happen, we know it happens, and we will work diligently with our patients and their families to get them through these things. For any additional information, you can look at some of the following websites to go over pharmaceutical and financial resources that are available. I know personally that the manufacturers of the different immunosuppression medications also have assistance programs to help patients get their medications should there be a hiccup after surgery with insurance. You just never know. Sometimes you can do all the planning in the world and something happens and you temporarily lose insurance. And there are ways to sort of get around that. And if that does happen, it's always very important to stay in touch with your transplant social worker so that that person can sort of help guide you through that process. And that is the end of the talk, and we're happy to take any questions that you all may have. Thank you so much for listening.
Thank you so much, Dr. Sodhi. You've led such an excellent and informative webinar. Now I'd like to take the time to ask you a few questions that we've received over the course of the webinar.
Sure.
So the first one is, if you experience rejection and have to go back on dialysis, at what point do you need to stop taking immunosuppressants?
Oh, so this is a great question. So if the kidney has reached the end of its life, or if there was a complication that requires a patient to have to go back on dialysis, different centers handle this differently. It sort of depends on the age of the patient and what is going on at the time. A lot of times, centers will wean you off of immunosuppression medications completely over the course of a month or two. If you are young, and the kidney has reached the end of its life and there's the potential for you to be able to get another kidney transplant, a lot of times they will try to maintain those patients on very low levels of immunosuppression just to prevent them from forming any further antibodies that could sensitize them against future kidney donors. So it's sort of dependent on the patient, but a lot of times we will try to eventually wean everybody off.
Great, thank you. So what is the general recommendation for how soon a kidney donor can go back to work as well as a kidney recipient? And they'd like to know for jobs that do and do not require manual labor.
Great question. So our kidney donors, I'll start with them. Usually those patients are discharged from the hospital within 2 days of surgery, and they usually go back to work within 3 or 4 weeks with no restraints whatsoever, and that is, or restrictions, and that is mainly because their surgery is usually done laparoscopically and is not an open procedure. So those patients have a very, very short recovery time. For the kidney transplant recipients, typically we make them wait anywhere between 8 and 12 weeks before they go back to work, and a lot of that just depends on how well and how fast the wound, the surgical wound heals. And when they do go back to work, we usually tell them if you are doing manual labor, not to lift anything heavier than 20 pounds for the first 2 to 3 weeks. And if they do okay with that, then we slowly start to increase their weight limit week by week. I usually tell my patients, you know, if you're doing okay with 20 pounds, go up to 25 to 30 pounds for a week. See how you do with that. If everything looks okay, go up by another 5 to 10 pounds the following week until you're, you know, where you need to be. Usually these patients are being followed very closely in clinic around that time anyway, so we can inspect the wound and make sure that everybody is being safe and we're protecting the patient.
Right, thank you. So are there limitations on traveling to foreign or developing countries due to the risk of infection?
So I really like this question because the reality of the situation is, you know, with the advancing of technology and the world is just small now. So we do have patients who have family overseas in different parts of the world, and a big reason why they want to get a kidney transplant is so that they can go back and visit with their families. That there is a risk involved in traveling to other countries. So usually the first year, at least at our center, we tell patients not to travel internationally. We do let them travel within the country, usually after 3 to 6 months, as long as there haven't been a ton of complications. And then if they've made it out a year with relatively few complications and everything's stable, then we let them go internationally. What I tell patients, my best advice is if this is your goal and you know that this is something you want to do going into kidney transplant, it's very important to talk to your transplant centers about this because there are certain vaccines that you might have to get that you wouldn't be eligible to get after transplantation. So patients who are on immunosuppression can't have live virus vaccines. And so, that's a consideration if you know that you're going to travel to a different country and that's your goal and you're listed for transplant, we can give you those vaccines before you ever get transplanted so that you don't have to worry about getting them after transplant when you're not eligible. And also, it just helps if everybody that's involved with getting you through a successful transplant is on the same page. When we know what our patients' goals are, we all work together, and it aids in our decision making and how we handle certain situations, so that we're respectful of what it is you want to accomplish with your life, and so that we can get you to that point. But there is no restriction to travel to other countries as long as we know where you're going, we know how long you're going for, and how far out you are from transplant.
Right, that makes sense. So a healthcare provider has written in, they have a patient active on the transplant wait list, and this patient is non-compliant to their medications. Specifically, they have PTH levels in the 2000s, but don't want to take medications because of their concerns with side effects. So do you have any suggestions for handling non-adherent patients?
So this is a good question. Every center, handles these things differently. It sort of depends on the patient, but overall, I think for this particular situation, if you have a patient whose parathyroid level is going up and they are unwilling to take their binders for whatever reason, or their Sensipar, whatever it is you're using to control their parathyroid levels, then really the next step is to do surgery, because what you don't want to do is transplant a patient whose PTH level is that high. It can cause a lot of complications after surgery. But the bigger issue really is that I think it's important to have a discussion with your patients if there are medications that they're unwilling to take, because a lot of centers will look at that and say, if this person doesn't want to take this certain medication, we don't have a guarantee that they're going to be willing to take their immunosuppression. And the reality of the situation is there's an organ shortage in this country. We have way more patients who have end-stage kidney disease than we do kidney donors. And so we have to be somewhat selective about who gets listed for transplantation. And at a lot of centers, unwillingness to take any medication, regardless of what it is, can be used as an exclusion criteria. So I think it's important to, be open with your patients, explain these things to them. A lot of times patients don't realize that either. So when they find that out, then all of a sudden they're very willing to take medications. And some people still aren't. So I think it's important because, like we talked about earlier in the webinar, a lot of the immunosuppression medications have side effects, and some of them are easier to deal with than others. But it's really not optional if you want that kidney to survive to just not take those medications. So I think having a good dialogue with your patients is important in that instance.
Right. So someone is concerned about the risk of cancer, and they have asked if a transplant drug causes cancer in a young person, or if that can happen, will they lose their new kidney, and what can they do long term?
Sure. So there's a lot of sort of information that flies around the internet about the link between cancer and transplantation. And the way I sort of explain it to patients is the following. So any transplant patients, regardless of whether they're kidney, heart, lung, liver, intestine, whatever it is, any patient where you're altering their immunosuppression can be at risk for, it can be at an increased risk of developing cancer later on in life. And the reason is this. So I've never had cancer before, but that does not mean that I've never made a cancerous cell before. So like I said earlier when I was explaining immunosuppression, the reason that I've never had cancer is because whatever cancerous cells I've made, my immune system has identified those cells as abnormal and tagged them for destruction so that they don't replicate. And so when you start messing with someone's immune system, you mess with the ability of the immune system to correctly identify abnormal cells. And so that's why any patient on any sort of drug that alters your immune system is at an increased risk for cancer. The patients that do develop cancers, particularly most often the most common cancer that patients develop after surgery, after transplantation, is actually skin cancer. So what we tell our patients is just to stay with a dermatologist. We encourage our patients to see a dermatologist once a year for a checkup, or if they start developing skin cancers, to follow more frequently. Usually those are pretty well managed just with Mohs procedures, and we tend to lighten immunosuppression if you start getting multiple skin cancers. If we've had patients that have developed breast cancer, and again, most of these cancers are very responsive to immunotherapy, and the patients usually tend to go in remission. Most of the time, these cancers don't affect the function of the kidney or the life of the kidney. And especially if somebody's already getting chemotherapy, we actually will even hold their immunosuppression while they're on chemotherapy, and the kidneys do just fine. And then once the patient comes off of chemotherapy, then we put them back on low doses of their immunosuppression. Most of our patients don't have any problems.
Great, that's really good information. So someone has a specific example that pertains to them. They've asked, how can I explain absent time as a result of kidney disease to future employers? I am 44 years old and have been out of work for 5 years. That's
a great question. So, we always want our young patients, especially the ones in their 40s and 50s, to go back to work. It is difficult to foresee what complications will come up because every patient is different. But I always tell my patients, when you're going for job interviews, be upfront. So if you're in a job currently and you want to return to that job after transplant, you need to be forward with your employer and say, look, I'm getting listed for a kidney transplant, and so I will need, I'll have to be out during the time of the transplant, probably for 3+ months. It's usually 3 months. Sometimes it can be longer if things don't go well, but it's typically 3 months. And then if you're interviewing, or if you are thinking about going back to work, and you're still on disability, or you're still, getting your ESRD financial support, we usually tell patients, if you wait until about 6 months after transplant, the risk of complications is so much less frequent that usually it's really not a problem to go back to work, because you don't need a ton of time off. Really, the only time off you need is for doctor's appointments, and the frequency of those doctor's appointments after the first 6 months is much less than it is right after the transplant. And a lot of times we do with our patients, like if we know that they have jobs and they need to come into the hospital, we try to arrange for their admissions on Friday afternoon so they don't, they can take off, so they don't have to miss work. And they can stay through the weekend. Usually the doctors and the support staff are pretty good about trying to keep people in their jobs. So it tends to work out okay for the patients.
Thank you. So question about diabetic patients. For diabetic patients who don't get a pancreas transplant, what type of management is suggested for diabetic medications post-transplant, post-kidney transplant?
Oh, this is my favorite question. So I love this question, because what I tell patients who have longstanding diabetes, especially patients whose kidneys failed because of the diabetes, that it's really important, if it's possible, and it's not possible for everybody, but if it is possible, to establish care with an endocrinologist specifically dedicated to diabetes management. And it's not because primary care doctors don't do a good job. I think they do a fine job. I think endocrinologists, though, are a little more experienced with dealing with transplant patients in general. Diabetes tends to get worse after transplantation. And the reason for that is because as your kidneys fail, you clear out less and less insulin from your body. So whatever you're injecting and whatever your pancreas is making tends to stay in your system longer than it would if you had a kidney that was working properly. So a lot of patients on dialysis or with failing kidneys have less and less insulin requirements. Some patients on dialysis don't even take insulin. And then all of a sudden we give them a kidney that's working 24/7. and all of a sudden their blood sugars go way up. And I'll have patients come back to the office within a month of transplant, and they'll say, my diabetes went away, and then you gave me a kidney and you made it come back. Well, the reality of the situation is the diabetes actually never went away. It was just easier to manage when the kidneys weren't working. So the other good thing about establishing with an endocrinologist is that there are a lot of oral medications in addition to injectable insulin that patients become eligible for when they get working kidneys and they have good renal function. You can't give a lot of those medications to people who have end-stage kidney disease, but when they get a kidney that works, they become eligible for those, and those can help to regulate blood pressure so they're not injecting themselves with as much insulin. So I always encourage patients, if they can, to see an endocrinologist. If they live in an area where there is no endocrinologist, because that's the reality in the Midwest here, is that a lot of small towns don't have those kind of specialists, we just tell them to be very upfront with their primary care doctors to be very aggressive about their blood sugar control, because again, at the time of surgery, you get very, very high doses of IV steroids that can drive your blood sugars up. And so it's important to stay on top of those in the immediate post-op period.
That's really interesting. Thank you.
Yeah.
So we have one final question. Why is the kidney transplanted in the front of the body and not the back?
So the kidney is actually put in the front of the body because to go into the back where the native kidneys are, you'd have to take out the old kidneys, which can be a very extensive surgery. And we found that if you use the vessels that supply blood to the lower abdomen and the legs, you can actually plug the kidney in there nicely and put it close to the bladder, so that you can connect the new kidney to the bladder without needing a long ureter, which is the tube that connects the kidney and the bladder. And the kidneys work just fine. So, and again, because you're not going into the abdominal wall and into the abdominal cavity, you're just going on top of it and just under the skin, you can avoid a lot of the complications from a big abdominal surgery. The native kidneys will actually just shrivel up and they become non-functional and don't really cause a problem. So we kind of have found that if you just leave those alone and implant up front, the patients do much better and they recover from surgery a lot faster.
Great. Well, thank you. And thank you so much for leading this webinar. It really was very informative, and I think it'll be informative to many people as they view it.
Well,
so thank you everyone for listening today.
Well, thanks for having me.
Okay, let's see. I'm going to end the webinar. If this cuts off our call, I'll give you a call back.
Okay, no problem.
I just want to make sure I get this recording.
Yeah, no problem.